I'm focusing for this talk on lymph node transplant and specifically the abdomen as a donor site. I don't have to tell you why we're doing this or why lymphedema is a problem. I think everybody in this room knows and sees patients and hears the stories, but it is a significant problem, and I think it behooves us to, at every level, breast surgeons, every level, melanoma surgeons, to try to come up with a cure for this, because I think that the patients certainly live with this for the rest of their lives, and I think we have a great opportunity to make huge improvements in their quality of life. As I mentioned already, I think that we all do kind of the gamut of reconstructive procedures, and I'm very fortunate to have trained with many of the giants that are in the room here, and I'm very thankful for that. I also want to point out that in my practice, certainly, I think that the key, kind of the first funnel is a certified lymphedema therapy. As David just mentioned, nobody comes into my office or nobody will go to surgery unless they've proven that they are engaged with a certified lymphedema therapist and have at least had 3 months of very, very good therapy and have been compliant with very good therapy. They can come in and their arms are the same tan on both sides, and they say, oh, I wear my garment every day. We have a very serious discussion and they do another 3 months. So I think that none of these things will replace therapy. I think it's really kind of a synergistic model. There are very few patients, as David mentioned already, I think that truly don't need compression on a daily basis anymore after these surgical interventions, but that's a very, very small number. And even then, I think that certainly our patients continue to follow the therapist so long in case there is a worsening or recurrence. A couple of things that I wanted to point out, and we all, why I do these surgeries, why in my mind I feel it's worthwhile. The traditional teaching has always been that lymph fluid passes through the lymph nodes and then gets returned into the venous circulation somewhere else, the thoracic duct, accessory thoracic duct in the right neck, things like that. So the teaching that is still being, I think, perpetuated in medical schools certainly today is that. So why do we think that if we're adding lymph nodes into an area that would have any impact on the patient's outcome in terms of the reduction of lymphedema? I think that Mingwei really, to me, kind of has championed that thinking in that he's shown after transplanting lymph nodes into an ectopic site that he was able to demonstrate that the dye that was taken up into the lymphatic system in the subdermal plexus entered into the lymph nodes and then was found in the venous system of the efferent venous system of that lymph node. So there is a connection where molecules, where fluid can enter the lymph node and can actually be absorbed into the venous circulation at the level of the lymph node. And that's when I saw that, it was a little bit of a light bulb moment for me in the sense that I thought, this is worthwhile. We now know there is a connection. There is the lymph nodes themselves can actually siphon some of this fluid off this lymphatic pump. So I think that's incredibly important. The other thing that the pressure of up to, I think David alluded to this, we're always thinking of the lymphatic system of being a very low pressure system. But there was a really elegant study done in Brussels by, and I'm blanking on the gentleman's name now, I apologize for that. But they inflated a see-through blood pressure cuff on a limb and did an ICG injection on the arm and then saw at what pressure, when they slowly relieved the pressure, at what pressure the ICG traveled through the lymphatics past the cuff, past the blood pressure cuff. And they actually found that the lymphatic system generates pressures of up to 100 or even slightly higher millimeters of mercury. So that intrinsic pump mechanism is probably stronger than we had anticipated beforehand. So again, then in my mind, that's why I feel confident that these lymphovenous bypasses, and David's obviously shown much of the outcomes already, but from a physiologic point of view, I feel confident that there actually is something to this, that there's actually the ability to dump lymphatic fluid into the venous system. Anyway, so as I mentioned, I want to concentrate on the vascularized lymph node transfer, and I know that some of the other speakers will focus on some of the other donor sites. I'd like to concentrate on kind of my preferred donor sites. As I mentioned already, there are a number of different proposed effects of why we believe that lymph node transplants work. Again, I'd like to point to Mingwei's work because I think that in my mind is probably one of the most profound ones, that we can see that there's actually fluid entering the lymphatic system at the level of the nodes. What do we do with our patients? The perioperative treatment, as I mentioned already, that there's absolutely everybody sees a certified lymphedema therapist. It's a minimum of 3 months before we intervene in any way. And it needs to be a good partnership where there's a dedication from the patient as well. And then at least 12 months, we generally follow our patients for the rest of their life. So far, it's only been 4 years that I've been at Ohio State, but we plan to follow these patients forever. We do, as Dr. Broersen has taught us all, I think a volume is extremely important. So we do have a perometer, which made it a little bit easier for us rather than the very frequent circumferential tape measures, although we still do those, maybe not every 4 centimeters, but probably every 15 to 30 or so. And we do those measurements preoperatively and then at intervals for at least 2 years postoperatively. We are administering the LymphQ for all of our patients to try to get some measure of patient perceived outcomes as well. And for all of our surgeries, really, we do cover patients pretty aggressively with antibiotics, even though these are clean operations, but we're always concerned about infection with that patient population. Again, just to show you, there have been obviously other groups have shown good outcomes with lymphovenous bypass, with vascularized lymph node transfer. In the interest of time, I'm not going to belabor this, but to just show that everybody has pretty similar results. I think most people will show about a 60 to 70% of their patient population will have a measurable volume improvement, depending a little bit on the stage of the disease with this type of intervention. This is my plug. I think other speakers will convince you of other things, but in my mind, the extra-abdominal lymph node donor sites, they all have their drawbacks, as do the intra-abdominal ones. But some of the drawbacks that have kind of led me to look at the abdomen as a donor site, the greatest one really being the risk of giving lymphedema to someone. And I know we have very elaborate and very sophisticated methods now with reverse mapping to try to avoid generating lymphedema in a donor site, for example, the groin or the axilla. But it's still, on my mind, it's still one of the biggest fears. And so that was one of the reasons to look for other areas. The submental region, I think there probably is no risk of giving lymphedema in that area, but there is a small risk of nerve damage, and certainly to me it's a visible scar. I know Mingwei's results look beautiful. I'm not sure that I'm able to reproduce that beautiful scar under the mentum. So what do we have available in the abdomen as a donor site? There are really 3 sites that we've looked at so far and that seem to be potentials for transplants for lymph nodes. And the omentum one, and I think Alex Wynn has championed that technique a great deal and has done a great number of cases with beautiful results. When we looked at the omentum, and we certainly used the omentum, and I'll show you when, there aren't that many lymph nodes in the actual omentum, and the lymph nodes that are there, they're really kind of clustered along the greater curvature of the stomach. They're in the omentum proper, in the apron itself. There really are lots of lymphoid lakes, but no real lymph nodes. And so the question is, what do we need the lymph nodes, or is this lymphoid tissue good enough? And we don't. I think on a physiologic basis, we don't know the answer. We know it seems to work and it seems to have the same results as lymph node transplants, but it certainly is relatively devoid of lymph nodes themselves. The mesoappendix, we were super excited. We really thought this is the answer because it's in a completely expendable part. Patients will thank us. They'll never get appendicitis. We can do this laparoscopically. There's a great vessel. They're usually 1 millimeter to 1.5 millimeters for the artery, about around 2 millimeters for the vein. So certainly technically doable as well. And there was actually from one of Mingwei's colleagues, there was a single case report. As we were doing our anatomic dissections, they reported transplanting the mesoappendix. But what we found when we looked at this in specimens, appendectomy specimens, that there was a lymph node, a single lymph node only present in about 8% of patients. The remainder had not a single lymph node. Again, tissue very, very rich in lymphoid tissue. The appendix thought to be a lymphoid organ. We haven't used it as a transplant yet because we're not quite sure what the mechanism would be of functioning. The single patient that's been reported has shown some improvement as well, but as a lymph node transplant, it doesn't qualify. Now, one tissue that we've always noticed that being extremely rich in lymphatics and lymph nodes is the mesentery to the small bowel, and that's really become our workhorse for lymph node transplants. It's abundant in lymphatic channels, and you can actually perform anastomoses of the lymphatics as well, but also is very rich in clusters of lymph nodes. Again, omentum, abundant in lymphatics, milky spots, lymph lakes, but has very few lymph nodes attached to it. It's a great tissue to transplant because the blood vessels are very easily dissected and they're very, very large. So it's a nice surgery, and you can take multiple slips of this, multiple portions, so you can actually stage this, or you can do multiple transplants all at one time for this organ. I'll show you when we use it. This is a picture from Alex. He was kind enough to lend me this because I think it's probably one of the most dramatic changes, certainly skin changes, that I've seen in a patient. And Alex does usually takes the entire omentum and essentially degloves the leg over the area where he places the omentum. And then he did the CT with dye here and showed that it lights up beautifully. You can see here the volume reduction is probably not as profound as it would have been because the omentum itself is quite bulky. But that's not lymphedema anymore. That's a significant improvement for that patient. I talked about this already. Mesoappendix certainly technically would be a great operation to perform. Can be done quite nicely laparoscopically, especially in a non-inflamed appendix. But it unfortunately doesn't have any lymph nodes with it. Yeah, that was our findings. So we focused on the mesenteric transplant for the smaller packets that we place distally, and we usually use the omentum for the proximal transplants, where we combine it with a significant scar release and then feel that we need a larger piece of tissue to actually interpose in between the tissue planes to actually maintain that scar release, rather than just having the scar reform after a scar release in the axilla, for example. But for the distal transplants, we looked at the mesentery. We started this off with looking just at cadavers to see how many lymph nodes there are, and we found that actually the majority of the lymph nodes, or greater numbers, are in the proximal third, and especially if you're looking at the peripherally located ones, they're slightly higher in the proximal third of the small bowel. This is just a transillumination. You can see those tiny little dots. The beauty of this flap, in my mind, or this transplant, is that you can see all the lymph nodes before you harvest them, and you can see the associated blood supply before you harvest it, and so you have the ability to try and pick and choose the ideal site, and obviously you also can see that you maintain the vascularity to the bowel throughout this operation, which is incredibly important. I'll talk a little bit more about the kind of the distally placed, the lymph nodes that are more peripherally placed, as opposed to the ones that are more toward the root of the mesentery. The root of the mesentery, to me, is much richer in lymph nodes, but it presents a technical challenge that I'll address in a minute. What we do is usually for lower extremity like this, and you have both of the sites exposed. We usually use underbody and/or upper body bear huggers. We usually use a two-team approach. We can do this pretty nicely through a relatively small incision, depending a little bit, obviously, on the patient's body habitus. The reason that I think and this is essentially real time, it's a fairly straightforward operation. The reason that, this is a mini laparotomy. We've tried to do this laparoscopically, and have not really been very successful with it for two reasons. It's very difficult to transilluminate the mesentery laparoscopically, and you still have to get your omental packet out of the abdomen, so we still have to make just about the same incision to get that packet out without damaging it. So we do this, we transilluminate extracorporally here, and we pick the segment of jejunum that we like, or the lymph nodes that we like, and even while transilluminating, much of the dissection can be carried out. We do ligate those the more significant vessels, and we try to leave the peritoneum on one side intact to avoid an internal hernia in the future. But this way, to me, it makes it a very straightforward operation. I feel very confident about the blood supply to the lymph nodes that we do take. They tend to be very small packets, and so I think these are not great. They're not very well suited for a proximal placement of lymph nodes, because generally in the groin or in the axilla, there's usually a significant amount of scar release, and it's a much larger wound that needs to be filled. So I think these small packets that are about 3 or 4 centimeters in length just don't lend themselves for that. I think the omentum is a much better option for that. You can see here the peritoneum is spared on one side, and then we just either perform an end-to-side, and I'll go into that, or end-to-end anastomosis here, packet of lymph nodes. We used to use skin grafts over top so that we could monitor it with a percutaneous Doppler. Now we're just very aggressive about thinning the dermis over top, making a little pocket for those lymph nodes, taking some of the fat out, and then we can actually percutaneously monitor them. Where do we put them? And I think there's still a long debate going on about that. Is the proximal or distal placement more appropriate? In my mind, and what I've been observing in my patients so far, if the majority of the swelling is distally, then definitely placing the node distally would make a greater impact, and a greater impact sooner. I think the proximally placed lymph nodes do help, but they tend to help the proximal part more quickly, and it takes 2 or even 3 years to see any kind of change in the distal part. And then it'll be, in my hands so far, it's not complete distally. I think that so if distal is the problem, place the lymph nodes distally. If proximally, if there's a significant amount of scarring, what we end up doing now is we put them in both places. A couple of things that are just more for the people who are going to undertake this. I think there are some vascular considerations for these, and I think when you take those flaps, especially the mesenteric ones, you have to consider that the blood flow is a tremendous amount of blood flow goes to the bowel. These little lymph node packets are just a bystander that are just watching this highway of blood flow essentially going along. And so I think to just take the main blood supply and not perform a flow-through flap or a distal AV loop or something of that nature, I think is a mistake, because I think you get a tremendous imbalance of flow. I think it's not very physiologic, and I think we've lost the one node that we've lost early on. I think that was the mistake, that we took large blood vessels but didn't connect that flow and just relied on that small little capillary bed to connect those to the arterial, to the venous circulation. So now what do we do? If we find lymph nodes that are peripherally located, they have a much smaller blood vessels that have, I think, a much better balance through that smaller lymphatic, through that smaller capillary bed. If we're taking some that are proximally located, we always perform an AV loop, or we do a flow-through flap. I think the other things that I wanted to show is just a little bit of the technical aspects of kind of how to pick a flap that needs to be performed as a flow-through flap or with an AV loop versus an end-to-side anastomosis into the vessels. The other thing that I wanted to talk to you about a little bit is I think more and more we are doing, the nice thing about the donor side of the abdomen is that you can do multiple flaps from the same donor side. So we're more and more doing double flaps where we're placing an omentum proximally and this mesenteric packet distally, which is very easily accomplished through the same incision. Our results, I think, are very, very similar to what we've seen in the literature in terms of the improvement. Again, about 60% or so of patients have a measurable improvement in their volume after this operation. We find somewhere between 9 and actually 18%, and we're still very early in the, in the data collection. Actually are probably free of compression after this operation. So we're very pleased about that. But again, there's a very significant patient population that is not helped by this operation, and many of them that will still continue significant compression. The other thing that I wanted to highlight is our complications, because this is certainly not without. You're performing a laparotomy. We haven't had any bowel injuries. We've had all of our patients resume a PO diet on postoperative day 1 except one of them. And that was associated with very significant adhesolysis as well. She's had that patient had multiple prior abdominal incision, multiple prior abdominal surgeries, as well as some radiation. So she resumed PO diet on post-op day 3. We've had 2 patients in our series of about 60 now that have had a bowel obstruction, both of which was a single incident, and both of which resolved with just a fluid diet for a couple of days and then resolved, and we've not had any recurrences, thankfully. We have had 2 bulges, 1 hernia in patients, and I think that comes back to your comment. We are not limiting this operation to a BMI of less than 30 or 35. We do have patients that are larger, and they're obviously at much higher risk. And in those patients, we're now considering putting a prophylactically and a resorbable mesh in. But so far, knock on wood, we haven't had any major complications with this operation. I think the results are very comparable to what my colleagues with other lymph nodes will tell you today. So thanks very much. Sorry for the technical difficulties.